Hi everyone, let's go through an interesting case today. A patient, a 32-year-old male, presents with fatigue, petechia, and persistent fever. His CBC shows anemia, thrombocytopenia, and leukocytosis, with a few circulating blasts on peripheral smear as hemoglobin is 7.2 grams per deciliter, platelets are 45,000, and total leukocyte count is 18,000. So far, this feels like a straightforward hematological malignancy, but the real question is, what exactly are we dealing with? At this point, you're thinking along the lines of an acute leukemia or possibly a high-grade myelodysplastic syndrome. Now here's where things get interesting. The bone marrow is hypercellular, and the blast count is 12% on a 500-cell differential. If you were following older classifications, this would comfortably fall into MDS with excess blasts. But look closely at the morphology. The blasts are large, with abundant cytoplasm, and importantly, you can identify long, slender auer rods. Some cells even show those characteristic salmon pink granules. These are subtle, but very important clues. So now we have a dilemma. The blast count suggests MDS, but the morphology is hinting towards something else. This is exactly the kind of case where you cannot rely on blast percentage alone. Flow cytometry shows a blast population of around 12%, expressing CD34, CD13, CD33, and MPO, consistent with myeloid lineage. But here's the key finding. These blasts are also expressing CD19. Now this is not random. Aberrant expression of B lineage markers, especially CD19, in a myeloid blast population is a major red flag for translocation. 8:21. So when you see CD19 in an AML case, don't ignore it. It's not noise, it's a clue. And this is confirmed on cytogenetics. The karyotype shows translocation, 8:21, Q22, Q22, and molecular studies detect the RUNX1-RUNX1T1 fusion transcript. Now the diagnosis becomes clear. Even though the blast count is only 12%, the presence of T821 is sufficient to diagnose acute myeloid leukemia under the current WHO 5th edition classification. So the final diagnosis is acute myeloid leukemia with defining genetic abnormality translocation 8:21 with RUNX1-RUNX1T1. This case teaches a very important lesson. In modern hematopathology, genetics can override morphology. If you rely only on blast count, you will miss this diagnosis. And this is exactly why understanding these diagnostic traps is crucial, not just for exams, but for real-life reporting. If you found this case helpful, make sure you follow along, because we'll be decoding many more such high-yield cases together.